Yeah, if we focus on the symptom, it's difficult. But we could identify some specific patients who has a genetic mutations. So these are the genes which has a causative relations are already demonstrated. Especially BMPR2 is the famous to cause the pulmonary arterial hypertension. And other than BMPR2, there are several genes identified as causative genes for pulmonary arterial hypertension. And as you can see here, most of the genes relate to so-called TGF-beta superfamilies. So among those, BMPR2 mutation is the most common cause to develop PAH. So if one has a BMPR2 mutation, there is a possibility that he or she would develop a PAH, although the penetrance of this gene is like only 20%. So in other words, even if one has a mutation in BMPR2, only 20% of the people would develop PAH. But even though it's still genetic testing would have benefits, including that prognostic information, and we could perform a personalized treatment if we know that one has a mutation or not. And familial risk assessment could be done. For example, if we identify one patient with PAH and with BMPR2 mutation, then we can screen their families. And if one has BMPR2 mutations, 20% of those patients would have developed the PAH. And with those information, we could do early diagnosis of asymptomatic family members. So this is one of the very good study published in a couple of years ago that screening for pulmonary arterial hypertension in adults carrying BMPR2 mutations. So these group collected the PAH patients and checked the genetic mutation in BMPR2 and select patient who, actually not patients, but relatives carrying BMPR2 mutations and asymptomatic. So this one, so they have no symptom at all, but they have BMPR2 mutations and perform the right heart catheterization to check the hemodynamics. And out of 55, 2 had pulmonary arterial hypertension in inclusion, although they do not have any symptoms. And after that, those patients were followed like 2 years, and 2 years follow-up resulted in 3 new patients. So as I told you, in general, 10 to 20 patients out of 1 million people, but in this case, as a total, 5 patients in 55 people. So this is very effective way to identify new patients. So based on these, this ESC and ERS 2022 guidelines recommend the counseling regarding the risk of PAH and annual screening are recommended in individuals who test positive for PAH causing mutations like PNPR2 mutations as a class 1 and evidence level B. So in the last June to July, there was an annual symposium of PH was held in Barcelona, in Spain, and there they suggested that genetics and precision genetics approaches to pulmonary hypertension. And they recommend that patients should check the genetic mutations, and after genetic counseling, so they may have pathogenic variant, or they may not have pathogenic variant. And after that, the family members, after the appropriate genetic counseling, to check their mutations. And if pathogenic variants are identified, then even though they are asymptomatic, they have no symptoms, they should get regular follow-up, including symptoms and clinical examination, or CPET, or echocardiography. Then, actually, who should get those genetic investigations? In the case of adult, idiopathic PH, hereditary PH, and congenital heart disease or VVOD, this is venous disease, or drug or toxin-induced PAH. And in pediatric cases, in addition to group 1, group 3, developmental lung disorders or congenital diaphragmatic hernia should get the mutation, the genetic, to identify the genetic mutations. And even though asymptomatic family members, those tests are recommended. Then, which genes should we check? So, of course, BMPR2 is one of the most important genes, but in addition to that, those are the risks which should be investigated. So, this is the guideline from Japan. So, in our country, again, these are the recommendations, which is very similar to ESC and ERS. And again, the genes that should be investigated almost same as ERS and ESC, but there is one exception. These genes, RNF213 genes, this is known as so-called moya-moya disease and abnormality of the brain arteries. And this gene would cause the pulmonary arterial hypertension. And this abnormality is very restricted in East Asia or Southeast Asia. So these genes also should be checked. So, as a summary, early diagnosis of PAH and timely intervention are associated with better long-term outcomes. Therefore, the genetic screening may provide the early detection of PAH and offer the timely management. So, coming back to the first question, is it possible to prevent pulmonary arterial hypertension? And I would say that genetic screening could prevent the progression of PAH by early detection and timely management of the disease. However, currently, I have to say that it's difficult to prevent the onset of PAH. However, there is a possibility that the development of PAH could be prevented by combining genetic screening with the avoidance of second hit factors. So one of the good examples should be like congenital heart disease and associated PAH, because if one has ASD, atrial septal defects, usually, at least in Japan, the development of PAH is very rare. I know that's not the case in this country, but our common sense is ASD is okay. However, if one has a genetic mutation and ASD, then there is a high possibility to develop pulmonary arterial hypertension. So in that case, the early repair would be very beneficial for him or her. And also, another example is the connective tissue disease-associated PAH. In this case, if we treat connective tissue disease by immunosuppressants or steroid, maybe we could avoid the occurrence of PAH. But this is another story, so this time I would skip it. Okay, thank you very much for your attention.
Please, Prof. Come forward, please sit beside me. Thank you, Professor Imoto, for your talking about screening and genetic counseling to prevent PAH. In the last slide, he already answered the question. But we're still curious about is it possible to detect and screen in pediatric population, because some of the pulmonary arterial hypertension occur during pediatric phase. Therefore, we would like to invite Professor Indah Kartika Murni, MD PhD. She is a professor of pediatric and Department of Pediatric, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, and pediatric consultant in cardiology from Dr. Sarjito Hospital. Professor Indah Kartika Murni, please come forward. She will give talk about pulmonary arterial hypertension in pediatric patients, focus on screening and early detection. Your time to talk is 20 minutes. Prof. Indah, please.
Good afternoon, everyone. Thank you for the organizing committee who have invited me to speak on this topic of the pulmonary hypertension in children. So during the next 20 minutes, firstly, I would like to talk about the definition of the pulmonary hypertension, as well as what is the type and also the cause of pulmonary hypertension. Perhaps I would like also to talk about the clinical symptom of this kind of situation, because when we would like to screen or early detect of this pulmonary hypertension, we may know what is the hemodynamics as well as the clinical symptom of this situation. So as we know that the pulmonary hypertension is actually a pathophysiological state that defined by the increased mean pulmonary pressure exceed 20 or 25 millimeter mercury after 3 months of age in term babies. Why it is 3 months? Because as we know that in fetus, the pulmonary vascular resistance is still high, and it will decrease significantly after birth when the lungs begins oxygen exchange, and reaching levels that are comparable to adult values within 2 or 3 months. So as you can see here, that in the normal heart, that the blood flow is evenly distributed to across all lung segments. But in pulmonary hypertension, as you can see that there is any vasoconstriction, so it can make the increased pulmonary vascular resistance as well as increased pulmonary arterial pressure This means that there will be any regurgitation of the blood coming from the right ventricle to the pulmonary artery. So it is can increasing as well the right ventricle pressure. Because of there is any increase in right ventricle pressure, it can also make the tricuspid valve regurgitation and raising the right atrial pressure. So this situation can lead to congestion of the systemic venous system. This systemic venous system, if it is congestion in pulmonary hypertension, it may lead to reduce the blood flow to the lung, so it can cause the hypoxemia and will limit the return blood to the left heart, so it may cause decreased cardiac output as well as limiting the low output, so it can cause low output syndrome. So that's why the clinical manifestation of pulmonary hypertension in children, so we can see whether any shortness of breath on exertion, tiredness, also syncope, as well as the chest pain. This is the clinical manifestation of having a hypoxemia. As well as we can hear the loud second sound, the right ventricular heave because of the right ventricle hypertrophy, the systolic murmur of the tricuspid regurgitation, and also diastolic murmur of the pulmonary regurgitation. If the pulmonary hypertension is severe, then we can see the sign of the right heart failure, and as well as the low cardiac output syndrome. The desaturation in pulmonary hypertension can occur if only there is any intracardiac shunt. So we can investigate this kind of pulmonary hypertension, for example, using the blood biomarker, especially to evaluate the possible causes of the pulmonary hypertension. From the chest X-ray also, we can also early detect this pulmonary hypertension, but if it is possible, in early situation, it may be difficult to see the sign like this. From the pulmonary hypertension point of view, we can see the enlarged central pulmonary arteries, as well as the peripheral vascular pruning, and also right heart enlargement. From the ECG, we can see the right ventricle hypertrophy here, as well as the right axis deviation and also RV strain because of the increased right-sided pressure of the heart. And to differentiate between the atrial septal defect and also the ASD with the pulmonary hypertension, we developed an ECG scoring system. So we evaluated about 144 children with isolated ASD, and we found around 35% that have pulmonary hypertension. And using this score, we have good sensitivity, moderate sensitivity with high specificity to include that this patient having a pulmonary hypertension in ASD. So from the echocardiography, if you can see, in the patient with pulmonary hypertension in normal one, so in normal patient, you can see that the IVC, it should be less than 1.5 millimeter during the inspiration, and there is any collapsibility more than 50% during the inspiration. But in patient with pulmonary hypertension, if you can see here that the IVC is more than 1.5, and also the collapsibility will be less than 50%. And from the apical four-chamber view, you can see there will be a normal size of the right ventricle and left ventricle with adequate function, but in heart with the pulmonary hypertension, with the heart with pulmonary hypertension, you can see that the right ventricle will be dilated as well as reduced right ventricular function and also some degree of the tricuspid regurgitation. This Doppler examination of the tricuspid regurgitation can estimate the pressure of the right ventricle in systolic phase using this Bernoulli equation. So in parasternal view, in the normal heart, that you can see the right ventricle looks smaller with the concave of the interventricular septum and also mild degree of the tricuspid regurgitation. But in the heart with pulmonary hypertension, you may see that the right ventricle is dilated as well as the severe tricuspid regurgitation and also flatten of the interventricular septum. And the parasternal long axis as well, you can see there should be balance between the right ventricle and the left ventricle with normal function and normal valve motion. But in this situation, you can see that the right ventricle is dilated and there is any flatten of the interventricular septum. And this also happening if you can see the septal curvature. In the normal one, it looks concave, but in this situation, you will see that the flatten of the interventricular septum in pulmonary hypertension. In the pulmonary, in the normal one, you can see that the pulmonary valve is quite normal in size, but in the pulmonary hypertension, the size is dilated with pulmonary regurgitation. So this kind of situation that you can see to early detect the pulmonary hypertension. But the cardiac catheterization is actually the gold standard to directly measure the pressure as well as to calculate the pulmonary vascular resistance. And this also can be benefit to do the vasoresponder rate testing because it can evaluate the possible treatment for the idiopathic pulmonary arterial hypertension, whether it can be operated or prognostic information. So next will be about what is actually the cause or type of the pulmonary hypertension. It is quite similar with the adult. So we have categorized into 5 groups. First one is pulmonary arterial hypertension. The second one related to the left heart diseases. And the third one is related to the lung disease and related to the thromboembolic pulmonary hypertension. And the 5th group is about the multifactorial mechanism. In our Department of Pediatric in Dr. Sarjito Hospital, as you can see here, the majority of patients with pulmonary hypertension belong to the first group, which is pulmonary arterial hypertension for 95%. It's followed by the left heart disease, which is contributed by the rheumatic heart disease, so about 3%, and then the lung disease. And for the group of the pulmonary arterial hypertension, the pulmonary hypertension is divided into 4 groups. First is associated with congenital heart disease, as well as the connective tissue disease, for example, systemic lupus erythematosus, systemic sclerosis, also the HIV, as well as the idiopathic heritable one, and the specific cause of the neonatal pulmonary hypertension, which is persistent pulmonary hypertension of the newborn. So we can see here that in the young children, the congenital heart disease and also PPH and still more are among the primary causes of the pulmonary hypertension. And this pulmonary hypertension that associated with congenital heart disease have 4 main categories. First is the Eisenmenger syndrome and the left to right shunt. And the third one is the pulmonary hypertension, but they have a small shunt. And the last one is the post-operative pulmonary arterial hypertension. In the post-operative pulmonary arterial hypertension, it is actually have the poorest outcome compared to others. And that's why we did a study to see what is the outcome of this patient with the left to right shunt after undergoing a closure of the shunt. And we can see here, we have the patient with the persistent pulmonary hypertension is around 25%, and the survival is inferior compared to the reversal pulmonary arterial hypertension. And they also have a lower functional class, and also in the lower functional class is also having inferior survival compared to the normal functional class. And we have collected the data for around 8 years in our hospital. So we have around 5,700 patients with congenital heart disease, and we have the pulmonary hypertension for around 14%. The most common pulmonary hypertension in here is from the left to right shunt post-tricuspid valves, which is VSD as well as the PDA. Why this is happening? Because as we know, in our hospital, 6 out of 10 patients, or around 60% of patients coming to our hospital with lately diagnosed of congenital heart disease. And if you can see here, that after the diagnosis was conducted in the first hospitalization or first admitted to the hospital, the pulmonary hypertension has already occurred in 15% patient. And you see that the patient with this kind of pulmonary hypertension, they also have mortality for about 16%. So the predictor of mortality in this patient if there is any syndrome, and also the lack of intervention done. So based on that situation, I can deliver to you that the pulmonary hypertension have a considerable morbidity as well as mortality. And that's why we need to perhaps screen or perhaps early detect this kind of situation to reduce this morbidity and also mortality. So what actually the screening of this pulmonary arterial hypertension, why we need to screen? Because the initial sign and symptom of pulmonary arterial hypertension are quite non-specific. As I mentioned previously, that the sign and symptoms, sometimes they came to the hospital with breathlessness or the short of breath, and also the fatigue as well as the syncope or perhaps the chest tightness. So they came to the hospital, the doctors seems and frequently consider as the another cause of the cardiac problems. And also the screening actually involves systematically testing to detect the disease before symptom appears. But in practice, it is often also include those with mild symptom or early disease. Because the pulmonary arterial diagnosis is often delayed, then screening may help to improve the early detection in symptomatic patient where the pulmonary artery hypertension is rarely considered initially. So if we would like to screen the patient, who will be screened for this situation? As mentioned previously by Professor Emoto, that actually because the prevalence of the pulmonary arterial hypertension in general population is very low, so it is might not feasible to do this screening for all general population. But we may consider to target the high-risk population that may have high risk of developing pulmonary hypertension. For example, those who have a congenital heart disease, as well as those who have connective problem disease, for example, with the systemic sclerosis or systemic lupus erythematosus, or having the portal hypertension or HIV, or any genetic mutation carrier. So for example, the screening or on the asymptomatic patient can be considered in this kind of situation. For example, when having this problem, or perhaps the liver, when they would like to do the liver transplant or genetic mutation carrier, or first degree relative that having the hereditary pulmonary arterial hypertension. But we can also do the early detection. Early detection meaning that the patient perhaps having at-risk patient with have a symptom. For example, in patient with perhaps systemic lupus erythematosus or HIV, or perhaps a congenital heart disease, we may do the early detection of the pulmonary arterial hypertension. So what would be the screen or early detection of this pulmonary hypertension? In some situation, perhaps we can do good history taking and physical examination. But please notice that the initial pulmonary arterial hypertension symptoms are not specific. That I mentioned previously, in the clinical suspicious of pulmonary hypertension, it is not early stage of the pulmonary hypertension. So that's why sometimes we need to have a tool that can screen the pulmonary hypertension. The one that may be considered to do for screening for the pulmonary hypertension is using the Doppler echocardiography, and in this tool we can use this echocardiography to measure the tricuspid regurgitation velocity, the IVS flattening, the reduce RVOT acceleration time, and also increase IVC diameter. But still, this situation may occur in the degree of the moderate as well as the late stage of the pulmonary hypertension. And that's why the echocardiography sometimes cannot be used as the screening, but it can improve the early detection of the pulmonary hypertension. And another tool that can be used as the screen or early detection of the pulmonary hypertension is the ECG, as well as perhaps you can use also the chest X-ray if you have the this kind of advanced imaging. You can also do with the MRI to see the treatment monitoring and also severity pulmonary hypertension scoring. And also we can do with the biomarker blood biomarker, for example, BNP and also anti-proBNP levels, because as we know, anti-proBNP released by the ventricle that have volume or pressure overloading because of increased pressure. So it may also correlate with the severity of the pulmonary hypertension as well as can predict the mortality. And we can also perform, for example, this pulmonary function test, because the classic abnormality, it will be a reduced diffusing capacity for the carbon monoxide with the normal spirometry, but seems that it is not a general screening for all patients. And the last one will be about the invasive cardiopulmonary exercise test. So it is actually the gold standard for the assessing pulmonary circulation function during the exercise, but because of this invasiveness nature, and also there is any arbitrary definition of the exercise of pulmonary arterial hypertension, and this kind of examination do not use as the standardized and also routine screening program. Well, this is, for example, a guideline for the screening recommendation that targeted the patient that have high risk of developing pulmonary hypertension. So, for example, this kind of systemic sclerosis, and also this, we can do the echocardiography annually, and also perform the biomarkers of the anti-proBNP as well as the pulmonary function test. And for example, the genetic mutation, we can also do the echocardiography yearly, and also the portal hypertension, when they will do the liver transplantation, we can also do the echocardiography. This can be done in the asymptomatic individual. But in congenital heart disease, for example, we will screen in this patient when they have a symptom. So for example, the echocardiography and also right heart catheterization will be done, and the thing that it is very important is we need to consider what is the cause of the pulmonary hypertension. If it is the left to right shunt, then please consider to repair the defect. Yeah.
Your time 1 minute, Dr. Rita.
Yeah. Well, it can be concluded from my talk that the pulmonary hypertension is actually meaning that increased blood pressure within the lung with a diverse etiology. Then when we identified a child with pulmonary hypertension, it is actually a beginning of the diagnosis. And the most common causes in children is congenital heart disease, and screening for the pulmonary hypertension should take into account the underlying causes of the pulmonary hypertension itself. And the early detection is enhanced by the understanding of the pulmonary hypertension hemodynamics. So before finishing my presentation, I would like to express my greatest gratitude to my senior in pediatric cardiologists, also esteemed cardiologists here, Professor Lucia Kristinarti, Dr. Wulan, Dr. Anggoro, also Professor Emoto and Dr. Kato, and all people who made this happen. Thank you very much for your kind attention.
Thank you, Professor Indah Kartika Murni, for your distinguished speaking. And now we'll move forward to the last speak by Dr. Diah Wulan Anggrahini. If Professor Noryaki Emoto and Professor Indah Kartika Murni already talking about screening and early detection, Dr. Diah Wulan Anggrahini will talk about how to diagnose pulmonary arterial hypertension using the pathway, which I hope it will make easier for us to diagnose pulmonary artery hypertension. Dr. Wulan currently is a cardiologist consultant of interventional cardiology, and he take care a lot of patients with PAH, especially those associated with congenital heart disease. Now he is staff in cardiology and vascular medicine department, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. Dr. Diah Wulan Anggrahini, please come forward to give your speech, and your time is 20 minutes.
Thank you. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much, Chairman. So this afternoon, I hope you all still have the spirit to open your eyes after the lunchtime. And we will discuss a little bit about diagnostic pathway of pulmonary arterial hypertension. I have nothing to disclose here, and by the definition of pulmonary hypertension from the latest symposium of the World Congress of Pulmonary Hypertension, it is a hemodynamic condition that characterized by elevation of mean pulmonary artery pressure more than 20 millimeter mercury. Of course, you cannot be able to measure it without right heart cath, but anyway, we will show you how that you would possibly notice some changes in patients who will possibly have pulmonary hypertension. And by the definition, actually, from the WSPH, the definition is more than 20 millimeter mercury, but for the treatment specific of PAH, specific targeted therapy, will be given when mean pulmonary artery pressure is more than 25 millimeter mercury and the pulmonary vascular resistance of more than 3 Woods unit. So actually, the pulmonary hypertension is a syndrome or a clinical condition by which it could be a result or it could be a consequences of quite several various clinical conditions. That's why there's a clinical classification of pulmonary hypertension in which it categorized into 5 groups. The first is idiopathic or with specific associated condition with a similarity in histology. And pulmonary hypertension associated with left heart disease, with lung disease, with pulmonary artery obstruction like post-pulmonary embolism, and with unclear mechanism. So I will show you the burden of pulmonary hypertension in our hospital. So in non-congenital heart disease, pulmonary arterial hypertension, the group 1, account for the majority of the patients who come to us into cardiology. So actually, we still have the underdiagnosis of patients with portopulmonary hypertension, those with PH due to lung disease, those with post-pulmonary embolism, and also the unclear mechanism, including those with the left heart disease. So these patients seems to be still under managed in our hospital. But when it comes to the congenital heart disease related, from around 2,000 patients referred to our registry, most of the patient, about 60%, comes with adult atrial septal defect, of course, because this will be late diagnosis. And 84% of patients with adult congenital heart disease suffer from pulmonary hypertension confirmed by right heart catheterization. And the long-term survival of idiopathic pulmonary arterial hypertension patients in our hospital, you see that the 5-year survival rate even is only about 50%, and the 10-year survival rate is only 40%. But with patients with Eisenmenger, in which there is a similarity in histology, morphology of the pulmonary vascular beds, the survival seems so much better than those with idiopathic pulmonary arterial hypertension. It's around 69% in 10 years and 86% in 5 years. So it seems that the presence of the intracardiac shunts probably is a better bailout mechanism for the patient for reducing the RV dysfunction. So when actually we have to suspect patient with pulmonary arterial hypertension, so here we have a female, 25 years old, referred to from the pulmonology department with chest pain. She's also having hypertension. She's having dyspnea on exertion or top-pneu and some signs of right heart failure. Actually, this patient has been diagnosed with systemic lupus erythematosus in 2018 with a specific treatment for that. And in 2021, she was treated for bacterial tuberculosis because of the dyspnea. The patient is having an NYHA functional class 2 to 3 with 6-minute walking distance is only 260 and quite high NT-proBNP level of 646. So for patient with pulmonary arterial hypertension, most of the patient will only report shortness of breath. So if you face a patient in your primary healthcare with patient shortness of breath, I want to know how many of you will be thinking of pulmonary hypertension. I'm pretty sure it's less than 50%. But I hope after this conference, you might be able to think of pulmonary hypertension as one of the differential diagnoses. So when patient is already reported with right heart failure, that means the progression of pulmonary hypertension is already going further. So the first is algorithm for suspicion of pulmonary hypertension. You have to see what is the underlying systemic condition or the risk condition of pulmonary hypertension in that patient. I already show you there are 5 groups of pulmonary hypertension, and we will show you later the 5 groups of the several disease that related to PAH or group 1. The second is you have to see the symptoms of the patient. What is the WHO functional class in this patient? Are they able to walk easily, or even are they able to talk easily? And the signs of PH, of course, if you already see the right heart failure, then it will, the condition is already severe. So this is some of the diseases that related to pulmonary arterial hypertension or the group 1. The first one is idiopathic. This is relatively difficult to diagnose. And the second one is heritable. This is also quite difficult to diagnose, especially we need the genetic examination. And when you see patient with connective tissue disease, HIV, portal hypertension, congenital heart disease, or even if you see patients with schistosomiasis, and when they come with shortness of breath, then you have to think pulmonary arterial hypertension is one of the differential diagnoses that you have to look for intentionally. And some patient with venous or capillary involvement, this is quite difficult as well. And when you see a newborn with the sign of pulmonary hypertension, then you have to think about the PH. So the step 2 is provide a simple non-invasive tools. It's very easy that you can do it in primary healthcare. Do the chest X-ray, do the ECG. From pediatric to adulthood, it's very simple. You can do the 12-lead ECG. So yeah, if you see the sign of, the warning sign of PAH, which is a right heart failure, then you have to just directly refer to the PH center. So this is the sign of chest X-ray for pulmonary arterial hypertension with a right heart enlargement, notching of the pulmonary artery, sometimes pruning of the peripheral vessels if it's in congenital heart disease. And sometimes we can see the water bottle shape because the heart is already too large. And so you can also do the anterior oblique of the lateral view to see the right ventricular dilatation. And the ECG will show the right axis deviation, the signs of right ventricular hypertrophy. Sometimes we can see the peak P wave, but sometimes we cannot see. For example, in patient with atrial septal defect, it will be very rare to see the pulmonal P or the right atrial dilatation sign. And the step 3 is for you who are familiar with echocardiography. I think some specific marker for pulmonary hypertension, you can evaluate it from parasternal long axis, where you can see the significant dilatation of the right ventricle. And then from fourth chamber, we will see the dilatation of the right atrium and right ventricle. And also you have to notice the tricuspid. When you see there's a TR, then we have to measure what is the gradient of the tricuspid valve. For example, in this patient, we see the 60 millimeter mercury, which is quite high. And the TR velocity of 3.8, we can measure it from the echocardiography. By this parameter, actually, so this is quite the same. We can see a lot of view for determining the signs of pulmonary hypertension. From short axis, in the mid ventricular LV wall, we can see the LVD shape, and sometimes we can see also the pericardial effusion, which show it's the severity of pulmonary hypertension. And if we see specifically for the IVC, we will see the dilatation and the decrease in the variation, respiratory variation of the IVC. So for the additional, we see some variable for the ventricles, pulmonary artery, and also the inferior vena cava. When we combine, we have this kind of signs. We can adjust it to the, this is a very nice algorithm by ESG. that if you see the TR velocity from 2.8 or more than 3.4, then we have the probability of pulmonary hypertension. Then you can just adjust it with the additional marker on echocardiography. If you see only one additional marker with additional TR velocity, then you have the low, intermediate, or high probability. By this, if you have high probability, then you have further referred this patient for right heart cath. So this is a comparison of the ESC 2022 and WSPH. Basically, it's almost the same, that by step 3 echocardiography, we can already know the probability signs for pulmonary hypertension, and we can decide whether the patient should need further right heart cath or not. So if the patient is having low probability of PH, then you don't need to worry. We just evaluate or monitor the patient. But if it's intermediate to high probability of PH, then we have to refer the patient. And for you who is in the primary healthcare, I think the ECG, chest X-ray, and also signs of the patient with associated systemic condition, you can always think that whether pulmonary hypertension might be there or not, then you can refer them further to cardiologists to see the echo. So if you have the sign of pulmonary hypertension, then you can further refer this patient if we want to see the perfusion imaging of the patient to see whether there's involvement in the lung disease or whether there's involvement of thromboemboli in the patient, to see whether the pulmonary hypertension is due to C-TAP or is it a pulmonary arterial hypertension, and then before we do the right heart catheterization. So this is the recommendation for right heart cath. Actually, for the patient who is having a high probability, it is a class 1 recommendation that the patient should be diagnosed as a gold standard with right heart cath. And in the patient without any intracardiac shunt, or the patient with idiopathic pulmonary hypertension, in the patient with hereditary pulmonary hypertension or drug-related, the vasoreactivity testing is required to see whether the patient is suitable for long-term calcium channel blocker as a therapy. So basically, well, since here most of you is doctor in primary healthcare, if you see the patients with already having an echo of intermediate to high probability of PH, then you should refer for right heart cath. Yeah, this is the example of right heart catheterization in that patient. So we see the MPAP. There's an increase in mean pulmonary artery pressure, so the normal is only 20. And this patient is having 30 millimeter mercury. The PVR is 6.6. And we see the pulmonary capillary wedge pressure 6 millimeter mercury. So we just see, based on hemodynamic characterization of pulmonary hypertension, so what is important about hemodynamic characterization? This characterization is created or is studied to provide or to guide us to classify the patient into which clinical condition that is the patient suit, the best suit. So for example, in pulmonary arterial hypertension, the patient should have the precapillary pH, in which the pulmonary capillary wedge pressure less than 15 millimeter mercury. Otherwise, if the wedge pressure is more than 15 millimeter mercury, then we have to be suspicious of the involvement in the left heart for the occurrence of PH. So pulmonary arterial hypertension will require MPAP more than 20, pulmonary capillary wedge less than 15, and PVR more than 2 Wood units. That is by hemodynamic classification when the patient, if the patient is diagnosed with pulmonary arterial hypertension. So, yeah, this is just a summary of all that the most important in patient with pulmonary hypertension is doing the clinical phenotyping, whether it's clinical and also hemodynamic phenotyping. Because the determining of group 1, group 2, group 3, and group 4 is very important for us to do the right management for the patients. So, in clinical presentation, almost all the groups will show the similar phenotype. And for the chest X-ray, for the PAH, we will see majority of the involvement in the right heart. And for the left heart disease, we will see the involvement of the left heart. You will see the LA, LV size increase. You also will see the signs of congestion. Sometimes you will see the Curly B signs in the chest X-ray. Then only by the clinical parameters, it's very easy for you to determine if patient is having signs of left heart disease or not. And for group 3, you have to see the signs of the involvement in the parenchymal lung disease, for example. Then we can, we can have a differentiate the patient, whether it's having pulmonary hypertension due to group 1, due to group 3 of the lung disease, or is it combined both of the group 1 and also group 3. And for the group 4, I think it's similar with group 1. And pulmonary function test. Pulmonary function test is really necessary if we want to differentiate if patient is having the involvement of lung disease. So by the measurement of, by the examination of spirometry, the LCO, and sometimes the arterial blood gas, we can determine the patient of the patient is having pulmonary arterial hypertension or the patient is having the lung-related pulmonary hypertension. So the LCO result will be much different because the LCO's score will be very low. Instead of in PAH, it will be still normal or mild to moderate. Yeah, echocardiography will show you the signs of PH, but in certain disease of left heart disease, we will be able to notify the involvement of the valve, the left ventricular function, the LA size, the presence of atrial, left atrial dysfunction. And VQ scan, we will need the VQ scan especially for determining whether the patient is having CTEP or not. Yeah, sometimes test CT scan is necessary when we suspect the patient is having lung disease to see the thoracic CT and the involvement of the parenchyma. For example, in patient with interstitial lung disease, we will see the abnormality in the chest CT. And sometimes we can notify whether there is a presence of pulmonary embolism or not. That will differentiate the type of PH for those patients. And CPET is basically to see the functional capacity and also VO2 max or the oxygen capacity of the patient. And of course, right heart cath, we have to differentiate the clinical phenotyping by the characteristic of hemodynamic in the patient by right heart cath. So in the PAH, precapillary pH character in the right heart cath is necessary. So as a summary, PH is still a burden with high morbidity and mortality, specifically due to right heart failure. And identification of early signs and symptoms is important to early diagnosis and prompt management. The screening of PAH is associated disease is necessary. So all the disease that is associated with PAH, you have to monitor and you have to follow up the patient for the signs of PAH. And diagnosis of PH needs multimodality approach. Is comprised of echocardiography as early identification, and right heart cath is the gold standard for confirmation and phenotyping of the disease. So at the last, I would like to thank on behalf of our team. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Ulan. Please come forward to the podium. Yeah, Dr. Ulan already gave a lecture about diagnostic pathway of pulmonary artery hypertension. But if you take an attention in the last slide, although he gave a lecture about diagnostics, he also emphasized that screening and early diagnosis is an important part of the diagnostic pathway of pulmonary artery hypertension. So I would like to open the questions for all speakers. Please, if you want to ask question about the lectures, please come forward to the microphone and tell your name and what is your question. Maybe start from this row. Any question? No? Not yet? Or from the middle row? the question about pulmonary artery hypertension, how to screen, how to diagnose, and in pediatric pulmonary artery hypertension. Or nobody still don't know how to, okay, please. Because this is one of the rare disease. Maybe not all of you have already seen the pulmonary artery hypertension, so that's why you have to ask for this session. Please tell your name and what is your question. Thank you. Okay, please the sound.
Oh, Prof. Indah and Dr.
Please come to the microphone so your voice will be clear. Yeah.
Check. Oh, yeah. Yeah. Good afternoon. Thank you, Prof. Noriaki Emoto, Prof. Indah, and Dr. Tia Bulan for the presentation. My name is Adi from Purwokerto. I would like to ask, how about the children from asymptomatic carrier of PAH, asymptomatic carrier of pulmonary arterial hypertension that the parents is screen positive in genetic screening? How about their children? Should we screen them in genetic screening, or is there any more efficient way to screen the children? How about the yearly evaluation of echo, or should we wait until the children had any symptom? And is it possible for the child from asymptomatic PAH carrier had higher risk for developing more severe PAH than their parents? Thank you.
Okay, I would like to summarize the question. The first is if the patient have a positive genetic mutation or genetic screening, what about the children of this patient? Is it necessary also to have screen? And if is it positive but still asymptomatic, what is the fate of these children of the patients? And for this carrier, it means the positive genetic but still asymptomatic. Is it can be more severe than the patient or the parent? Maybe Prof. Emoto first.
Thank you very much for your question. So the first question is for the how to screen.
Yeah, if the patient have a positive genetic in PEH and have a disease, what will be the children of this patient? Is it necessary to be screened? And if positive but still asymptomatic or carrier, what will happen is this in these children?
Okay, thank you very much. Yes, since I'm a cardiologist for adult patients, so I never deal with the kids. But generally speaking, yeah, I understand that depending on the age, it's difficult to express their symptoms, especially the kids have a very strong right heart, so that we should not rely on the symptoms. This is my guess. And of course, the EKG and chest X-ray would be a very good tool and easy method to check the presence of PH. But maybe, if possible, echocardiography would be the best. But yeah, I'm not the right person to discuss about that, maybe.
Yeah, thank you very much, Dr. Adi, for the question. So echoing Professor Emoto, so actually, perhaps if there is any patient with the mother or the parent have the genetic predisposition of the pulmonary hypertension, then in some papers they said that perhaps we can also check the children, but that also there may need debate because of if there is the result is also positive, then that will be what will be the problem, the next problem. And if there is asymptomatic child, so perhaps we can do, as Professor Emoto mentioned, that we can do the echocardiography is the best. Yeah, if you cannot do that, we can do also the ECG, but echocardiography perhaps the best answer to screen this kind of asymptomatic patient. Yeah.
So the next question is it possible that these asymptomatic children will become more severe than his parent if it develop pulmonary hypertension?
Yeah, the pulmonary hypertension, if I'm not mistaken, is actually the progressive situation. So it will be any progression. So that's why we may need also to screen in this kind of situation if there is any genetic predisposition, susceptibility, then it may consider to have screen for the echocardiography annually sometimes, because we can see that there is any progression or not. So if it is there is any progression, then we may early detect there is any problem, so we can also give the treatment or the drug efficiently. But if we can also mention that the drug actually cannot really stopping the progression, but we can also do the controller. Thank you.
So thank you.